staying tuned. It is still the conversation here on Lagos Television, and on this side, we are looking at a very critical issue here. September is Childhood Cancer Awareness Month, and that is why we are paying close attention to childhood cancer prevention and treatment right now here on the conversation. Childhood cancer is one of the most devastating health challenges facing a lot of families, not only in Nigeria, but all over the world. And to help us understand the realities of childhood cancer, efforts to prevent it, and how affected families can find hope and support, we are joined, ladies first, we are joined by Kemi Atolagbe. She is, I hope I got that right.
Yes.
Okay. She is the clinical patient navigator, Dorcas Foundation, and also with her is Korede Akindele. Did I get that right? Korede.
Welcome.
Korede Akindele, Chief Operating Officer, Dorcas Foundation. You're welcome.
Thank
I have the names right in my head, but it doesn't just come out the way it should. But you're welcome again to the conversation. And so September, like I said earlier, is Childhood Cancer Awareness Month. And let's begin to look at how prevalent is childhood cancer in Nigeria.
All right, thank you very much for having us. Thank you for, that wonderful question. It's something that we hear every time. Now, childhood cancer in Nigeria is becoming more prevalent. It's now one of the 5 diseases that children do have in Nigeria. Just like developed world, that it's on fast rising. It's something that has been existing, but now the awareness then is late, but now it's becoming more aware. People are becoming aware more that, okay, the children do have cancer. And then when you look at the burden of disease that affect children, childhood cancer is now the 4th leading disease that affect children in Nigeria. So the prevalence is getting more higher than what it used to be. It's an illness that has been there, but nobody pay attention to it because of social issues and the type of society that we have. But now, because of awareness, because of educations, people are beginning to aware that, okay, this illness might not just be a spiritual battle, it might be something that needs an attention, and it's something called cancer, and then it needs attention. So it's becoming known, and but we are so glad that the survival rate too is jumping up gradually than what it used to be before.
So my question is, I don't know who to direct this to, is why do we have to talk about this now? And secondly, what has environmental or biological factors got to do with childhood cancer?
Okay, thank you so much for that question. So, first off, the reason why we are talking about childhood cancer now is that September is Childhood Cancer Awareness Month, like you said. And this is just like a month where we can actually turn the spotlight on childhood cancer, why this is happening in Nigeria, and why this is happening all over the world. We are able to raise more awareness for a lot of people to know. And about environmental or biological. So the thing is, mostly, like, I won't say everybody knows, but people in the medical field know that, okay, till now, cancer does not have one particular cause, but there are biological functions, like sometimes it's family history. There is family history. So, and why clerking patients? Because as a patient navigation, I work in the hospital with the doctors. So while clerking these patients, you will see that the first thing we ask caregivers is a question that, so who has had cancer in your family? Is there any biological, is there any gene factor? So that we can point it back to say, okay, maybe this is where it's coming from. In the case where there isn't any, then this is just cancer manifesting himself. That is cells just not dividing the way they should. Yes. So that's
There's particular kinds of cancer that are more prevalent in children, and then what's the difference between childhood cancer and then cancer in adults?
So the word cancer is general, but there are some, just like you said, it's a cell that decide not to divide and become an issue.
Cancerous.
That become cancerous, either malignant or non-malignant, then it become an issue. So for children, there are some certain cancers that we see that rampant around children, and then one of them is the brain tumor, which is the cancer of the brain.
How old are we looking
the tumor, from 0 years, yeah. A child can have cancer from day of the birth. Yes, that's true.
Okay.
Even
So-
in the bed, I mean, they can even dictate something strong wrong and
Yeah.
bring the child out and do the surgery and
Mhm.
return the child back.
Mhm.
Yeah, it happens in developed country a lot. So we have retinoblastoma too. That's the
Right.
cancer of the eye. Yeah, that's
Mhm.
cancer of the retina. We have the Wilms
Leuke-
tumor.
Mhm.
That's the cancer of the kidney. We
Kidney.
have leukemia.
Okay.
That's the
Blood.
cancer of the
Of the
white
blood.
blood cell.
Mhm.
We have lymphoma. That's the lymph nodes. We have osteosarcoma, the sarcomas. That's the cancer of the bones, different part of the body. So these are more prevalent. So the ones we see around us more, like leukemias, the Wilms tumor, the lymphomas, that's the one we see mostly around us in this place.
You wanted to add
Yeah,
something?
in addition to that, so say the most common cancer would be the Wilms tumor, the one you talked about, the cancer of the kidney, where the child comes in. So as a patient navigation, what you do is when the child comes in and this cancer started, they have to go through chemo, surgery, then radiotherapy. But Wilms tumor is more prominent, and there's brain tumor too. So brain tumor is very, very prominent in kids. But the thing, your other question was children and adults. So with children, like my boss E actually, like he would usually say that as a parent, if your child is sick,
Boss, yeah.
if your child is sick, as a mother, you would not be able to get anything done. Because the child, if the child is uncomfortable, you as a parent, you would be uncomfortable. But as an adult, you can still say, okay, I'll go tomorrow, I'll go next tomorrow. So the difference is that let's just pay more attention to our kids, because sometimes they cannot even say what the symptoms feel like. That's why you need to see a specialist to see that child. Whereas adults can communicate how they feel and all
Because
of that.
it manifests itself like normal illness.
Yes.
Yeah, the child is just falling sick today and tomorrow, and if you go to the hospital, I mean, if you are not at work and you call him, the first thing he's going to say is, "Do you have malaria?"
Yeah.
That's the general thing. Or maybe you just go and take malaria drug and be fine. And then it presents itself like that. And then, I mean, as patient navigator, the see cases of people have been battling with malaria 6 months, 1 year, and then before somebody says, "Look, this thing is not getting better.
Can do an extensive
Let's do an
test.
extensive." That's so, and we understand that the way our health structure is, we have the primary, the tertiary, and the
secondary and the
the
tertiary.
secondary and the tertiary.
Yeah.
That's the system. And most people will go to
Primary.
where they know as primary health care that is closer to them. But what we try as much as possible to even educate people that works in the primary health care, those nurses, those community health care workers, those community extension workers, that look, when a child is coming to your center repeatedly, I mean, you've treated malaria in space of 2 months more than 6 times, then something is going wrong somewhere. Or a child that has never had transfusion before, and in the space of 2 months you've had transfusion 2 times, then something is actually wrong. So don't just refer the child to see a pediatrician straight. Don't say, "Oh, don't manage it." Just refer the child to see a pediatrician. And this people at primary health care worker too, we try to just educate them that, look, you can break that chain of pediatrician too. So if you as a healthcare worker understand these 1, 2, 3, 4, 5 things that can go wrong. So instead of moving the child to a secondary place that then we still have to move the child directly to the tertiary institution, which are teaching hospitals in our country, where the pediatrician are, the pediatric oncologists are. So immediately that child gets into that center, even if it's not cancer, that child will not leave that chain. He will see the right person that can handle
And
the
this will
case.
lead me. Okay.
I just want to stay with perhaps what to look out for. I've forgotten the numbers now in terms of the higher percentage of treatment we've seen, especially even in this part of the world. But I want to stick a little bit more with what should parents look out for. Now you've talked about whether you're falling sick over and over again, but some people will just say, "Look, mama, go to my form, and we're talking about babies. Like the only way of expression is to cry as much as they can to make you uncomfortable as well. So what other things should parents look out for? And perhaps we can look at the lymphoma, the leukemia, the blasmo, what would you call it, and all that. So what should they look out for? What are the symptoms that are visible that parents should, or especially those giving birth, should pay attention to?
When you talk about retinoblastoma, I think that's more common.
Okay, so
Retinal blastoma, that's for the eye.
Yeah.
yes. So let me start with Wilms tumor, which is nephroblastoma. So for nephroblastoma, I would say that's distended belly.
What is nephroblastoma?
That's the
Wilms
same
tumor,
as cancer of the kidney.
Okay,
So that's
don't put it like that.
That's another name for it.
The blastoma, it looks as if you're blasting us away.
Okay, so cancer of the kidney. So most of the time, the patients, that's the case, they present with distended belly. So the tummy is
big.
rounded and big.
Okay.
So, and that way, like he said, most of our mothers will be like, oh, there's something they can use, there's something they can use, which is actually wrong. Because we see these patients, and when they come to clinic, what you realize is that after couple of chemotherapy, the tummy comes down on its own, and then they go into surgery to remove that kidney, then come for radiotherapy, which would prevent reoccurrence of that cancer coming back. So that for nephroblastoma. So one thing about it is that, so most of the time cancer presents like normal symptoms of malaria and typhoid, and that's why it's always, like he said, when you go to the hospital and you are being treated for malaria too many times, they have to look into the symptoms more and look for what is wrong. And for retinoblastoma, cancer of the eyes, like he said, so it presents with headache. Most of the time, the children, they will be like, my head is hurting, my head is hurting.
How many years are you looking at now? 0 to what?
So
Well, for us now, we work with 0 to 24. Children, young adults, and adolescents.
Oh, interesting.
Yeah, that's what we focus on.
Yes.
Yeah.
Okay. So as I was saying, so the eyes, so you see bulging eyes. So the eye starts coming out more and more than it should. Then definitely at that point, you need to see the doctor. And even if the eye is not actually bulging out, but there is constant headache, that is another indication sometimes for brain tumor, especially when it's been treated and treated and treated. And if you see a specialist, the first thing they will do is probably an MRI of the brain to see what is going on in there. So
Just to add a little context to Kemi, I mean about the eye. If we take picture now in the dark, there should be a flash of red in your eyes. That shows that the eyes is actually picking the camera. But when you start seeing an eye of a child looking like a cat eye, you know, you've seen a cat, the way the eye, just whitish cat eye. There's a way the normal eye should be. But when the eye, so we have a survivor, his name is Perfect. Now, so they were having a free day at home, family time, and there was a power outage, and everywhere was dark. But our mother noticed that his eye is so wide, look at cat eye. What's this? What's the problem? They thought is, so in the morning, they were like, let's take this into the hospital, maybe cataract or something, and then they see a specialist and they say, no,
It's cancer.
this is something else, this is cancer. And they took the child to the hospital, they did chemo, they did the surgery. Today the guy is fine, the guy is bouncing around.
So from the stories that
So-
you have shared,
Okay.
Go on, just finish your
go on.
thought.
Finish it
So,
up.
so, like I'm saying, so those are the attention. So, like she said, parents has a responsibility on their child. That's just it. When a child is sick, like she said, you will not come to work this morning if your baby is sick. That's the reality. You say, look. So pay attention to the child's health. A child is active, suddenly become inactive. Something is wrong. A child is you're trying to touch his body and he's trying to withdraw. Then don't just pay attention and say it's fine. And we should try as much as possible to see pediatricians. They help a lot.
They're specialists.
They're specialists.
Kids.
Children. So from the stories that you have shared, it seems to me that there is hope that childhood cancer can be cured.
100%.
And that will lead me to, you've touched on it a little, about the importance of early detection. Because again, we are very religious and superstitious on this side, and with the not my portion, syndrome. So, when there are issues, people they say, oh, let me pray. We are not saying that prayer is not good, but while you are praying, please see a doctor, right? So how important is early detection? And, okay, answer that.
Early detection is as important as early. Like she used to use the word, when they say early is now. So how important it is so that's the determinant of it. Even if the cancer is, the focused attention on stage 1 and stage 4 is so different. Stage 4, there's a lot that you are battling with. But stage 1, the stress. I'm not saying that
the spread is not
the
there.
spread is not there. It has not metastasized. There's no stress. So it's so early detection is very, very, very key to survival of childhood cancer or cancer generally. And like I used to use the word most times, that in Nigeria, I've seen children diagnosed of cancer, treated and survive. Cancer-free, and back to school, doing amazing things for themselves in this country. But early detection. So early detection is important, and not just early detection, treatment, prompt and proper treatments, like we used to say, because treatment can be prompt and not proper.
Would you say that is the major challenge?
That's one of the challenges. Yeah, it's not just one of the challenges. Late presentation is one of the major challenges. Late presentation, treatment abandonment, as a result of different things. I mean, she's going to talk about radiotherapy systems. I mean, I'm going to allow her to share the part of treatment abandonment, what caused people to say, you know what, I'm going. Because, for example, maybe she wants to talk about it. Somebody traveled from the north. You want to talk about that process?
Okay, so
I love the way you pass the baton to her. Nice one. Go on.
okay, so like I was saying, so early is early. And a part of treatment abandonment is that, so for patient navigation, what we do is, once the patient presents in the hospital, we are like, okay, let's see the doctor with you. And when these patients, when they see the doctor, you know, obviously the doctor writes multiple tests. You have to do blood work, you have to do imaging, you have to do immunohistochemistry, you have to bring out back your tissue block. And we have patients that come as far as Adamawa, Yola. Another problem is limited treatment centers. Traveling down from so far, it's just a lot. So in that sense, they are there in Lagos. Okay, so we need all of these results. Let's put it together. So as patient navigation, you have to call those clinics to book appointments for them. They are able to go and do those tests and bring the results back. So because if you say, okay, go and do this one today, go and do this one tomorrow, patients, caregivers will tell you, see, I don't have TIFE and I'm not going to come after today. So you have to look for a way to book those tests on the same day as humanly as you can. And on the days that you can't do that, the foundation will be like, okay, so we need to do something about it, because Nigerian parents, let's put in mind that that child that has cancer is not the only child. There are other children and they have to go back to school. They still have other expenses by the side. So by the time they start radiotherapy also, radiotherapy is usually sometimes 3 weeks every day, Monday to Friday. And they are supposed to come for treatment every single day. So it gets to the point, sometimes 2 weeks into the treatment, the caregivers will tell you, see, I can't afford to come anymore. I do not have money. And sometimes when they even come, they don't even have somewhere to stay in Lagos, because Lagos is the only state that has radiotherapy machines.
What did you say?
Lagos is the only state in Nigeria that has radiotherapy machines.
In Nigeria.
There is a national hospital too.
There's
in
But
Abuja.
the most busy service is in
and in the couple, in last few months, we've gotten referrals from Abuja.
Maybe the machine.
Because I know because I know the federal government is doing something about the teaching hospitals, and they're providing some. So even so I don't know whether that is
they are
part
trying
of it.
to. They are.
I mean, there is work
working
going
on
on.
it.
There is work going on. So I think
Yes.
what she's trying to. I mean, we talk about treatment abandonment and everything. So she's trying to just bring out for. Ask her to share.
Most people still come to Lagos.
Yes. That's where you have the concentration and everything, and then.
And most referral letters are even given to
them to
Lagos.
see, come and see special. So
Lagos.
what she's doing is now when the parent comes, they don't need to go. You know, for example, you want to deal with Wilms tumor, cancer of the kidney. There's going to be surgery. You see a pediatrician, a pediatric oncologist, and then they have to book for you. Now, between then and now, it's a lot. Anything can happen. Maybe the parent can even run away if there's no. So what we do now is everybody now, there's something they call joint clinic.
Yes.
Okay.
Joint clinic, as a pediatric oncologist is sitting, a radiation oncologist is sitting, a neurologist is sitting. Everybody that needs to that particular kind of cancer that is to be there is sitting, and so they are dividing the case. So the parent is there. They are taking decision immediately. They are telling you what you need to do immediately. So it cuts that gap of you have to go and come back and say, I'm tired, I cannot do this again. And also there is an MDT, that it's not just one person thinking. It's all about, and it even cut across the globe. So I have a case in Nigeria, and they've done this case before in the US. So we sit together and say, see, we are dealing with this issue in our country, in our center here. What do we do? And they tell you, okay, this is how we handle it. You guys handle it like this, and we've seen better results.
So perhaps just to stick to this, so how do you handle people that say, look, I can't stay here any longer, I need to go? Do you provide accommodation for them? Do you reach out to government agency, or do government agencies wade into this? Or is there, because we literally pay out of pocket here for health services in Nigeria? We have preached about Idera Eco, and we have preached about so many HMOs are out there, but of course it's also for you to have an insurance that is also pricey in itself. You're trying to feed. So how do you handle this financial burden that this kind of ailment poses to parents?
Cancer is, go ahead.
Okay, so cancer is a lot actually. The treatment phase,
do you know that if you just hear that you have cancer, that is a killer.
Yeah, that
in itself.
Because even when they are being diagnosed, some parents still take like maybe 2-3 weeks to even come to terms with that diagnosis before showing up in the hospital, and that's another thing. So financially, it's a lot. But what we do is we try to cover as much as we can, and there's a program of ours called Home for Treatment. So for Home for Treatment, our patients that come from far away, we try to get an accommodation for them here. It's not a very big, we are still trying to develop the program. So it depends on the amount of time that they are using in Lagos. So we have short stay and we have long stay, the type of the stay in for the Home for Treatment. So for short stay is for chemotherapy. So chemotherapy, most of the time they're admitted in the hospital, so they give them the chemo maybe for 3-5 days, then just stay around to look at your side effects before you go back. But for radiotherapy, like I said earlier, sometimes 6 weeks, 7 weeks. We have a patient, David, he just went back to Benin. Yes, he came from Benin, and we had to get an accommodation for them to stay for 7 weeks, because the father said immediately the doctor was seeing him, and the doctor said, okay, so your treatment is going to be for 7 weeks. The man just said, what? Let me just go back to Benin. So we had to get an accommodation for them to stay. So that is what we still work on it. We still look for, okay, so this is how you can support us. This is how we can do it. This is how we can support you to get a home to stay. But aside from that, parents will actually just tell you, I'm trying my best, and sometimes patients even try to gather the money for the treatment. When you now tell them, okay, this is the amount of time you are staying in Lagos, realizing that they still need to look for an accommodation in a situation where they don't have relative in Lagos, that's another thing. Some people will just tell you, okay, let me go and look for the money. And before looking for that money again, cancer is cancer.
It's growing.
Time is growing. So
I want you to tackle some myths and misconceptions about cancer. Just yesterday, I saw a video online about I can't remember her name now, a white woman, and she was saying something about herbs to cure cancer. And I remember walnuts. I can't remember the other things that were mentioned. And I was reading comments, and some people were saying, oh, I tried that and it worked and all that. So I need you to, break this table.
So scientifically, I'm going to talk science now. Scientifically, it's not been proved that there is any cure apart from the laid down ones that we know and that is working now. That we know. People can know anything, but that we know and then we have seen worked. They say chemotherapy, radiotherapy, surgery, immunotherapy if it is needed. That's another form of treatment. Okay. Yeah. So, but the key 3 ones is either you do surgery to remove the tumor, and then you go for radiotherapy, and then you do with chemotherapy so that there will not be reoccurrence. So that is the standard protocol for dealing with cancer. So any other thing, I don't know. And then we advise people to please just stick to your doctor. Let your doctor advise you. I understand that the journey is not an easy journey, I mean, it's not an easy journey. Nobody ever, I mean, it's devastating to see people go through this, and to now see children go through this. It's so painful. But no matter how it is, your doctor, like you said, I mean, we are in religious society, people still pray, and then
See a doctor.
see a doctor.
Yeah.
I mean, pray that as the medication is going into your child's body, it should work.
working.
I have some notes here. I know you've touched on the role your organization is playing in reducing the burden of cancer treatment in children and their families. Perhaps you can touch some more on that. But I would like you to speak to the recent development and progress made for diagnosis, treatment, and support of children cancer in Nigeria.
So, like I said, I mean, this question, I'm always happy to answer it because, I mean, this joining process, it's been 10 years
And this-
that we've been doing this as an organization. And like I used to say, that what we see 10, 15 years ago is completely different now. There is advance in care. There is advance to access to care. She talks about radiotherapy centers. Yes, we have radiotherapy centers with LINAC machines here in Nigeria, which was not like that before. Now, our pediatric oncologist is super. Now, she talks about they've been super before, but now there's more coordinated effort about your work to their joint clinic, to their multidisciplinary. Now, Nigeria is part of WHO Global
GICC.
Initiative for Childhood Cancer, which is GICC. I mean, it's a lot. It's a big step forward towards the improvement of care for us in this country. And I mean, Nigeria will be hosting a pediatric oncology congress next year. So all those are leap steps that has moved us from where we used to be now and then to where we need to go. Yes, we've not get there, but we are on our way going to. So our care is, access to care is advancing through multidisciplinary team, through joint clinics, through working groups. Now, for example, there is a working group that physician has. It's called retinoblastoma. This retinoblastoma we'll talk about. There's a working group of there are specialists in Nigeria that's their area. They deal with it. They are brain surgeon. They deal with it. So we now have working groups that says, okay, these are people that have interest in retinoblastoma care. So you are in Lagos, you are in Ibadan, you are in Ilorin, you are in Ogbomoso, you are in Abuja. So everybody is like in a bowl now, trying to suffer. So those things has moved us forward from where we used to be. So access to care is improving. Education is improving. So education, even not just from the professional education, from the lower level. So all those are moving. So we are not where we want to be yet, but I tell you, we've moved.
Progress.
I would like to add to that. So diagnosis. So for diagnosis, I would like to add that. So unlike before, when we send patients with their immunohistochemistry, so immunohistochemistry is a test, a tissue block test. So what we do is, sometimes when they bring out their results from their states, the doctors there like to do something called second opinion. So ask them to retrieve the tissue block from wherever they came from, maybe Osun State or wherever. So
Why Osun?
So we ask them to send it back to Lagos. So from Lagos, we take them to labs there. We have like a ton of new labs. And before, this test usually take like 3 weeks. But now we have newer diagnostic labs that within 5 to 7 days, the results are out and we are able to treat efficiently.
So we are moving.
So
Pediatric oncology is moving.
So are you limited just to Nigeria, or you're developing partnership in the sub-Saharan Africa, or because of the...
We have amazing partnership. And I mean, if you talk about, in the US, if you talk about the hospital that treats pediatric cancer, you talk about St. Jude Children's Research Hospital.
Yeah.
And we have a close partnership with St. Jude Children's Research Hospital. The hospital in Lagos here, I mean, the federal hospital here is a member of the St. Jude Global Alliance. And our organization is also a member of that Global Alliance. And so that partnership gives us a lot of advancement in our work, both the clinical work and in the foundation work, the support work. So it gives us access to knowledge, it gives us access to expertise and support that we need. And I tell you, it has improved our work. So we have, partnership across Sub-Saharan Africa, not just Nigeria alone. There are other foundations that are put in Nigeria that we can say. Somebody called me from Abuja now and say, oh, sorry, I have this patient, I can't fly to Abuja now. And so we have working relationship and say, okay, there's a patient that is trying to that needs help. Can you guys come in? So basically, and you asked the question about advanced care.
Yes.
All those collaborations are what is helping us. We have education programs that we have facilitators outside the country that runs it where we have a series of education going on in this September Childhood Cancer Awareness Month to develop the capacity of us. So our collaboration is huge. Collaboration with WHO, collaboration with St. Jude, collaboration with Childhood Cancer International, CCI, who are like a parent organization that run advocacy for childhood cancer. So these are viable partnerships, and also with Nigerian Cancer Societies. These are viable collaboration that has moved forward in pediatric oncology in Nigeria.
All right, you've said a lot about what you have been doing, but again, how can individuals, organizations partner with you to also help pushing this good work?
So the first thing we'll say, so individuals, partners, or anyone interested is, come to the ward, come and pay the children a visit. It goes a long way. Last week we were still in the ward, an individual, an organization, I can't mention them, they came in. 2 weeks ago we had a very prominent person also. The first step is just come and see them, come and pray with them, come and sit down with them, talk with them. It goes a long way, because most of the time when you enter the ward, these patients, they've been there for 3 weeks, 4 weeks, some of them 2 months. And just to know that you are thinking of them, you are praying with them, is a long thing. It really brightens their day. And sometimes these individuals, they come with coloring books, pens, do these activities with the kids. You can also volunteer with us. You can donate to a child. Our social media pages, you see all the children we are helping. Right now we have like 5 children on waiting list that their parents cannot afford treatment, and we are looking to support them. You can pick a child and donate towards the cause. If you want to add anything.
I think she has talked about it. The most important thing for us is people, the reality is there, and people need to know. So you can just, like you said, just come and pay visit. A word of encouragement a lot. That, oh, somebody remember me from LTV. Wow.
So Joy, you're talking to me. So my own, do we need to go now?
We can still take your question.
Okay, so my own final question to you is, I don't know the story that you need to share that will perhaps cheer up someone, perhaps give them hope today. You have one is bubbling in your mind as to perhaps just give us how it started in just a few words, just summarize it, and why you feel that was one of the happiest day of your life, looking that this guy or this girl has you have
both.
You have 2 stories. Okay, share just, and this is what I am called to do.
Okay, so I'll share the story of Samuel. Samuel was diagnosed when he was about 9-10. So he was diagnosed with cancer of the kidney, nephroblastoma. So we onboarded him on the ward. We met the mom. The mom was tired, exhausted from all of it. So we took over his case. We started helping with treatment and all of that. And after the chemotherapy, he did his surgery, he did his radiotherapy to prevent recurrence. Then it was fine. Samuel was okay, he was really good. He went back home and he resumed school. Only for us to know that when we talk to Samuel, he's down a bit. Samuel, what's wrong? What's happening? He will say, nothing. What's happening? Nothing. We're now like, okay. And we have this other program, Back to School. We're now like, would you like us to change your school and all of that? And now, the last time we had our survivors together that we were speaking, the thing Samuel said that stood out to everybody and we owed to our hearts was that he said, I'm grateful that you guys changed my school. And we're like, why? He said, because in his old school, they knew he was sick. And then when he got back, he was bullied. That sicky boy. Now, Samuel has graduated SS3, just graduated this year. And he's going to, we're preparing him to go to the university. And he wants to be a medical doctor.
That's cool.
So that's Samuel. So there's this other child, Inioluwa. We call her Iron Mama. Inioluwa was also diagnosed with Wilms tumor, and now she's in basic 9 like they call it now, JSS3, and she's still in school. She's in boarding school. So whenever I go there, because I go there for visits and all of that, and I'm like, Inyolo, hope they're not stressing you. She will tell you, Miss Kemi, who wants to stress me? Have you seen me? I'll say, Mama, the mama. And I still want to too, please. He's 7 right now.
Okay.
He's 7 in
He's
Nigeria
7.
right
Oh.
now.
Yeah.
And he had 2 different kind of cancers. It started with lymphoma. We treated lymphoma, it was fine. Then leukemia came in.
I think Timothy has been on this show before. With
Yes,
that.
yeah, you brought him on the show before, and now he's 7. He was in the office, I think, a month ago, and he's doing very well.
All right. Stories of hope that you have shared on the program
Maybe
today.
I
We've been
should just
talking
help
about. Okay, go ahead.
Yes, so thank you very
Oh,
much.
yeah.
Chief Operating Officer, Dorcas Foundation, Mr. Korede Akindele. Thank you very much. It's a pleasure to always hear from you. You sound so calm that we don't know that you're going through a lot with these patients. And we have the clinical patient navigator of Dorcas Foundation, Kemi Atolagbi. It's a pleasure to have you join us.
Thank you
Thank
so
you,
much.
sir.
Thank
Thank
you,
you,
LTV.
Ma. Thank you for
Let me just say
having
this as I found. I mean, LTV has been with us consistently for 8 years.
Yeah.
And we are grateful. Thank you very much for giving us this platform every February and September to raise awareness, to talk about it. On behalf of the children we are supporting and the management, thank you.
Okay, thank you. It's our
Thank you.
pleasure. That's the least we can do. So we'll take a very short break. When we come back, perhaps we'll get Jibola's thoughts on this. Jibola, you are not going anywhere. We'll take a short break. Don't go anywhere. We'll be right back.